Welcome. Appreciate the kind introduction, Parth, and appreciate the invitation by UCSF to do this for all you folks. I'm going to move on. My charge is to talk about medical management of BPH, which in part really is also evaluation, and I'm going to throw that in for free. Disclosures, mandatory, actually not much there. First things first, I hate doing this, but we need to talk about some definitions. And what we really want to talk about is LUTS, lower urinary tract symptoms, because BPH is this benign enlargement. We're going to speak accurately anyway, and I would encourage you to do that. It is not hypertrophy, it is hyperplasia. What referring physicians mean when they do an exam and say, hey, he's got BPH, they likely talk about prostatic enlargement. And then the sequelae is obviously the bladder outlet obstruction. Sometimes we use these interchangeably, but really it's LUTS is what it's all about. So I've mentioned the hyperplasia. It's hyperplasia. It's proliferation of these cells. And lower urinary tract symptoms, all kinds of causes, a number of symptoms. We're going to boil it down into kind of what I call the 7 cardinal symptoms, and I'll talk about that in a second. You probably periodically hear about zonal anatomy, and I know there's a whole spectrum of residents listening today, and so I don't want to belabor this point, but what we're really talking about is enlargement of the transition zone that begins someplace in the late 20s and then continues, in most men, continues to grow for the rest of their life, and that is the BPH part of the prostate, the transition zone. Less than 5% of total prostate volume in a 20-year-old, but can be the majority of the prostate volume later in life. Now, this is one of my favorite slides. This comes from the Olmsted County study where they assessed not clinic patients, but men living in the community around Mayo Clinic. Very famous study. And the red line shows that 1.6% increase in prostate growth per year. So these men had ultrasounds, community men volunteered, came in, had an ultrasound repeatedly over a 7-year time period. And on average, you see that prostate growing relatively slow. Each line represents one patient. So you can see this man, his prostate went from 60 grams or something up into the 70s during this period of time. And his cohort, age-matched cohort, is a line down here someplace. And this guy had very little prostate enlargement. But if they came into the office, you would treat them the same, even though this guy is fundamentally different than this guy down here. So what's going on? So for your in-service and kind of conventional etiology of LUTS BPH is this, a static component and a dynamic component. The static component is that increase in prostate volume that occurs over time. I'm old enough that when I was a resident, this was the BPH of BPH LUTS. This, and me urologist, me cut out, patient get better. That kind of idea, prostate growth. In the early 90s, late 80s, actually, Herb Lepore and other investigators really promoted this concept of a dynamic tone of the prostate, primarily increasing the smooth muscle contraction of the bladder being a more prominent cause of lower urinary tract symptoms. So really, they're not mutually exclusive. They both compete. But I will tell you that this is wrong. Now, for your in-service, stick with this slide. But for reality, it's really more like this, where there's this big multifactorial, multiple causes of the symptoms. And yes, obstruction is important, but we forget about the detrusor overactivity. I'll talk about nocturnal polyurias in a second, and then a whole other host of things, including systemic disorders, the central nervous system, sleep disorders, all contribute to lower urinary tract symptoms. So that's hard. It's a little bit different concept, but this is really where the field is. Couple of things I wanted to say again, because I know there's a spectrum of residents listening. The size of the prostate does not correlate to the symptom severity. I mean, I wish I had a nickel for every time someone said, "Oh, I did a rectal, his prostate was this big. He must, he has BPH." Those are disconnected, in part that dynamic tone, and plus those other multifactorial issues which may be driving the symptoms. So be careful causally linking those two. The idea is there are differences between men, even with one particular prostate volume, because the capsule may be different. The location of the hyperplasia may be different. It could be a strategic location of prostate tissue. And then, the central nervous system, as I mentioned, moderates this, maybe accentuates these symptoms. And of course, the bladder is not independent in here. The bladder is a player. So anyway, it's more complicated than just prostate got big or prostate got tight. When we transition into treating lower urinary tract symptoms, keep your eye on the ball, and that's the symptoms. It's important that as you discuss options with patients, that they get a vote on this. It used to be controversial. And it's certain, as primary care physicians have taken an appropriate increasing role in the management of LUTS BPH, there are circumstances when it should be sent to us, and I'll detail that in a second. In the past, it was controversial that primary care would have any role in here, and frankly, I'm glad. I'd rather handle the ones that aren't managed sufficiently well in primary care. I'll take those guys. So this comes from the 2011 AUA guidelines. And I put this on here to scare you for a couple of reasons. One, this is great fodder for questions for in-services and your board exam. It's a guideline, it's got data on it, and you're kind of responsible for it. But it's totally intimidating and it's confusing to look at it. So a couple of things I wanted to mention. Number one, this is in the guidelines, so it's totally accessible to you. But when you have a complicated presentation, these types of issues, then maybe that's the time when primary care should step out. That comes right down to when it says specialized management. That means us, urologists. But when patients walk in to see us for the first time, you should be doing a few things. I'll explain these in a second. But I want to make a focus here that this is underutilized, this idea of the frequency volume charts. That reveals so much. It is free, it's homework for the patient, and importantly, leads to better care, because when you start doing frequency volume charts, you can separate out these other causes of polyuria, nocturnal polyuria, important things to know about. So if you're going to spend any time looking at the guideline, look at this box, and this box. That's what I wanted to say. Now, this is the second part of that same flow diagram and the algorithm. And the idea, of course, is to intimidate you. No, not really. The idea is that this is what we're going to talk about today when we talk about medical management is down here. But I'll have this presented in a second in a slightly more friendly way. And I think you might get something out of that. Okay. The initial evaluation, the patient walks in. This is right off of what you just saw. You got to take a history. Please use a symptom score. It is so useful, and just get used to doing it now. Every patient that sees me, first visit or their 100th visit, I make them do this. It really helps me kind of focus in on the problem. I'll explain the symptom score in a second, but it really I would look at it as a standard. It's actually recommended. Obviously, you can do an exam, a urinalysis. I'll mention that in a second. And then I asterisk the PSA because that is part of our guidelines, but certainly you want to take that in context and context about PSA. And I've already mentioned the voiding diarrhea enough. Okay, the symptom score. This is called the AUA Symptom Index, sometimes the AUA Symptom Score, or the International Prostate Symptom Score. There are subtle differences between the AUA score and the IPSS, the quality of life, the 8th question, but they have the same mother and father. They are the same product. And we arbitrarily, at the beginning, divided these into mild, moderate, and severe by the demarcations you see here. As it turns out, Later on, McVary and a group from Boston did some more patient interactions with the score, and it turns out that our arbitrary divisions correspond beautifully the way patients self-assess. When their scores are 7 or less, they say, yeah, my doctor, my symptoms are mostly mild. When their symptoms are 19 to 35, then the patient would say, hey, they say, yeah, God, these are severe symptoms. So it corresponds nicely, fortunately, that we divided it according to the way patients interact. And so again, critical. Patient comes in, he's got a symptom score in the 7 or 6. It's hard to make an asymptomatic patient feel better. So don't drive. Urinalysis, a couple of things I think are important. Why do we do this? Well, you look for infection. You'll look for blood as alternate causes for LUTS. It might tip you off a carcinoma in situ or some other issues. But 2 things which I think as urologists, it is our job to look for glucose and look for proteinuria, because I guarantee you the primary care physicians miss this. In fact, the glucosuria assessment is so critical. I put it on here twice. Because many times a week, I'll get patients in for recalcitrant LUTS. I look at them, they're spilling sugar like crazy. They have an obligate diuresis, and you are not going to make that patient better unless that glucosuria is improved. So you can throw all the alpha blockers in the world, and if he still has glucosuria, he's going to have to get up at night. So focus on that when you look at the UA. That's the real reason that we do that. Physical exam for lower urinary tract symptoms, it's so simple, even a urologist could do it. It's a focused exam looking at the lower pelvis and a neurovascular examination. A couple of things on the DRE, which I still advocate for. We don't really do it for size, because even with gray hair, digital rectal exam is unreliable in estimating prostate volume. We tested that. And even the emeritus professors aren't much better than neophytes. Smaller prostates are overestimated on digital rectal, and larger prostates are underestimated. So you're doing it for other reasons, like prostate cancer assessment, and that's a whole nother talk, but also the neurologic examination that comes with the digital rectal examination. All right, active surveillance. Obviously, this is not ignoring patients. It's re-evaluate, not treating now, re-evaluating later. And really what drives that is the severity of the symptoms. When they're severe, most patients are voting for that. And the bother of the symptoms, and that's different. Symptom severity is different than bother. Some patients cope better than others, and so you can use that to adjust how you're going to do the active surveillance, or if you're going to do it at all. Note to self, if the level of symptoms are worse, then not so good, then active surveillance should be done more frequently. Instead of once a year, maybe every 6 months, because those with higher symptoms are at increased risk of having progression. We'll talk about in a second, BPH progression, and that's the proper use of BPH progression, occurring more frequently. A couple of rules. Watchful waiting or active surveillance appropriate for mild symptoms or patients with more severe symptoms, but they're not bothered. For instance, a guy is a farmer, and he has frequency, but he's out in the fields, and he has frequency. He's going to poison a few more weeds. No big deal. Next guy, he's the city mouse. He's in the city. He doesn't have that ability to do that. They are more bothersome for him. His ability to cope with that might be different. So given the same level of symptoms, one patient active surveillance, the other one maybe medical management. So again, you got to take it in context. There are circumstances when you don't do active surveillance. If they have renal insufficiency from bladder outlet obstruction, nope, you got to do some kind of intervention. Obviously, retention, reinfection, chronic retention, whatever that is. Why do I say it that way? Because we don't really have an effective definition of chronic urinary retention. There's no litmus test, unfortunately. So that's why the question mark. Couple of things about impact of active surveillance. There was a study, Bob Flanagan, former chairman of Loyola, did this study, published it back in the 90s, a TURP versus active surveillance study, if you can believe that. And one of the objects was to look at what drove patients to abandon active surveillance and go to an active therapy. In this case, it was only TURP. That's what it was. It was bother. Bother's the thing that drives them. So same level of symptoms, bother's the one that pushes men away. So bother is not, again, symptom severity. It's the way patients cope. It's an underexplored concept. Is there an impact if patients decide to do active surveillance? It's an important question. And there's evidence from this trial I just showed you, the watchful waiting versus TURP trial, the BA trial. And if you look at the placebo groups of the long-term dutasteride trials, in those two studies, you can see that when patients crossed over after a delay, after a 2-year delay, they never catch up with their peers, their cohorts. So there's a cost, there's an impact. And when I talk about active surveillance with patients, I say, well, there is evidence that you won't catch up if ever you cross over. But what we can't say is that that's bad for you, that it has some other impact. But it is clear that there is a expense to them. So when you use medications, remember, target is lower urinary tract symptoms, and the idea is to prevent progression. I'll explain that when I get to the IMTOPs. And of course, you want to improve patients' quality of life. Well, we're into alpha blockers now. That's the first one, and you're probably aware that there's a series of alpha receptors, the alpha 1A, the alpha 1B, and the alpha 1D. What happened to C? There's a story behind that. There isn't a C. But long story short, because of the location of the alpha 1A, which is in the smooth muscle of the prostate, and also probably the afferent nerves, the smooth muscle of the bladder neck, and a little bit, not as much, but some in the detrusor. So if you're going to give an alpha blocker, you would like to hit those particular receptors. Also, the detrusor is more alpha 1D, and so if you have an alpha blocker you wanted to use, having some alpha 1D activity might be useful. Alpha 1B is not here. Where is alpha 1B? Alpha 1B is primarily in the vascular tree. And so you'd like to have some alpha 1A exposure, some binding activity. You'd like to have some alpha 1D activity. You don't want alpha 1B because that's where the hypotension comes from. Alpha blockers used for hypertension, they have a stronger alpha 1B component. And that's the story. Okay, as prostates enlarge with age, the density of these receptors increases and the location changes. So as prostates get bigger, that density of receptors, the density of receptors increases in the bladder neck and in the smooth muscle of the prostate. Here's your choices of alpha blockers as it exists today. This is the story of my career. This column of medications right here. And I'll just go through a couple of those. The message is this. My own opinion, it is reasonable to consider these first lines. The AUA guidelines don't say that, but that is reasonable. That is what most people do. If you look at these agents, they all work about the same. There are ways to differentiate them, and the ways to differentiate them is, do you have to titrate? Yes or no? The adverse events that occur with those medications, and then the drug-drug interactions. That's the way to differentiate them. But when you look at flow rate and symptom scores, not much difference. Example, doxocycline. This is a 12-week study looking at 2 different doses. It was 4 and 8 milligrams, and here's changes in flow rate, and you can see a very subtle increase. By dose titration, there's a substantial difference between the control, the placebo control in this case. If we look over here, symptom score, and you can see, again, a modest improvement in symptom improvement by dose and a substantial difference between placebo. So just take a mind picture of that. Alfusis and another drug also called uroxetrol. And I would say these, when we look at the differences between placebos, there are some subtle differences, but the level of symptom improvement and flow rate improvement are pretty comparable. I don't really think it's worth trying to go and say, well, which one of the alpha blockers is working better because they're so close. Who cares? The other thing, these are, again, 12-week trials. And this is going to come up when we talk about the other major class. So this is 12-week data. And basically, in my own view, they work pretty much the same. I think I've explained this. The first couple of bullets, okay. When you look at adverse events, discontinuation rates are one way to look at, was the adverse event enough that it impacted patient behavior or physician behavior? And so you look at discontinuation rates. The big one, of course, is cardiovascular events. And when you look at the generic, older trazodone, doxorubicin, or the old alfuzosin, never available in the United States, it was a European medication, they have a certain baseline of discontinuation rate based on cardiovascular events, which are primarily hypotension, because they were developed for hypertension. In the later on, an intermediate release alfuzosin was developed, again only in Europe, but it had a lower rate because it was a slower onset of action. You didn't have the rapid changes in blood pressure. And then lastly, tamsulosin, silodosin, more subtype specificity. They had no alpha-1b exposure, and they have the lowest rate on cardiovascular events. But they also have higher rates for sexual dysfunction adverse events, which I'm not really going to talk about today. Okay, next class is the 5 ARIs, 5 alpha reductase inhibitors. I think probably you all know this pathway. There's a type 1 and a type 2, and the idea is these enzymes metabolize testosterone to DHT, and that's the active agent inducing this prostate growth, this slow prostate growth over time. The concept was if you can drive DHT to 0, the prostate involutes to a limited degree. How well does it work? Well, this is a famous trial called the PLES trial. It was a long-term study looking at finasteride, one of the 5 ARIs, impact on symptom score. So this was not the AUA symptom score when this study was done, when it started, because it wasn't invented then. But I want you to see the x-axis. This is years. And the alpha blocker you saw was weeks. So you can see a different impact. You can see an impact on symptoms with 5 ARIs, but it's a long game. You're measuring years. So you have to be on these medications for close to a year before you can begin to measure an impact on symptoms. If you're going to use this drug for symptoms, then the patient has to understand he's got to be patient. This is the long game. There are other advantages here, but for symptoms, this I think is worth remembering. How do these two types of drugs relate? Well, I put this on here. Type 1 and type 2 are kind of the issues. Finasteride's a type 2. Dutasteride does both. The plummeting of DHT is a little bit different between the two because of that difference in subtype specificity. Changes in PSA are essentially equal and also pretty equal in terms of decreasing prostate volume. But we give these medications I give these medications primarily to reduce urinary retention risk and to reduce the risk of patients requiring surgery. And if you look at those two reasons, so again, those are long game indications, not short time improvements, that these two drugs work pretty much the same. Now, this is a 48-month, this is 24 months. They're different cohorts. They shrink the prostate differently here because the duration's different. But ultimately, when we look at the outcome, they look pretty similar to me. 5 ARIs can impact patients crossing over to surgery or requiring surgery. And so, but again, it's a long game. The curves really don't separate much until you get closer to a year's time. So symptom improvement, yeah, it's okay, it works. Be patient, it's a marriage. Other hardcore outcomes, retention and crossover to surgery, again, long-term management, but you gotta commit to it. All right, MTOPS trial. This is the trial that kind of set us where we are today and how to use these medications. I think it's important to review it. And just by the MTOPS trial was a placebo-controlled trial of these agents, alpha blocker monotherapy, finasteride monotherapy, and combination drugs. If we look at when patients got randomized and follow them over 5, almost 4-point-some years, you can see the placebo, about 15-20%, having worsening symptoms. Their symptom scores rose over that period of time, at least 4. That was a way to endpoint. Monotherapies by the end of the trial, relatively equal, and the combination superior. If we take a look at a different outcome of the MTOPS, same idea, slightly different story. Here's placebos. The y-axis is like 2.53% here. And this is yellow is alpha blocker, green is the finasteride. In the initial phases, they seem pretty close, but by the end of the trial, alpha blocker actually is equivalent to placebo in preventing this outcome, urinary retention. It delays this, but does not prevent it. When you look at finasteride, monotherapy or combination, they prevent this outcome, the acute urinary retention outcome. So again, there's a difference, but again, you don't begin to see that till you get someplace out here in the 2-year mark. Displayed a different way is this slide, urinary retention by prostate volume. And I put this on because I had some early interactions when this was still released, and residents would come and say, hey, I saw a patient, I read your paper, I put them on both drugs. Wrong. There's a way to discern who needs to be on both drugs. One way is to look at the prostate volume. Let me explain. So here's the cohort in the MTOPS trial by treatment group, and those that had a prostate volume of approximately 40 grams or more. Placebo and alpha blocker, pretty close. Interesting, huh? But when you have finasteride in combination or monotherapy, there's a marked impact in terms of preventing this progressive outcome, BPH progression outcome. When you look at intermediate size glands, you see that there is a distribution, but again, alpha blockers combination probably outperforming the other agents. Alpha blocker is better than placebo. But when you look at smaller prostates, 20 grams or less, there's no impact of combination medication. So these deserve combination. Other prostate volumes don't. Prostate volumes determines outcome. From the 2011 BPH guidelines, they're here, how to use the 5 ARIs. It's reasonable, discuss its impact on retention and surgery. Can be used for LUTS, obviously, but again, long game. But what you really need to have is enlargement. You got to have prostate enlargement. That can be by some imaging test. It can be by a PSA, which is a great proxy for prostate volume, provided they do not have prostate cancer. And then we allowed digital, rectal, and cysto so people don't get sued. But regardless, you need enlargement, some evidence of enlargement. Another way of looking at it is patient shows up, you're trying to decide, well, what should I do with this patient? And so I have it displayed 2 different ways here. First, does the patient have no prostate enlargement of some kind? You measured it by some means, or lots of it. Does he have bothersome symptoms or not? So if the patient has bothersome symptoms and an enlarged prostate, think about combination drugs. If the patient has bothersome symptoms, but no real discernible enlargement, think about alpha blockers. If he has no bothersome symptoms, but a big, huge prostate, do you need to treat him? Well, there are some patients where you might. He has a valve and he's on Coumadin and you never want to see this guy in the OR. Yeah, that might be a good time to consider treating his enlargement. And you could just do 5 ARIs, frankly, because he doesn't have symptoms to improve with the alpha blocker. And if he has no enlargement and no symptoms, then you say, why are you here? So newer kid on the block, tadalafil. By dose, this is the second most common prescribed drug in the US anyway for LUTS BPH now. You can see the color code. Looking again, a 12-week study, that's your standard. And you can see by dose, these 2.5, 5, 10s, and 20s. The blue line here, this aqua line, is the 3-point change in symptom score. Why is that there? Well, at a 3-point improvement, patients can say, "Hey, doc, thanks. I sense an improvement." So all the doses have an impact, and you can see they all drop it that 3 points. 5 was kind of the magic point between this balance between more adverse events and an improved lower urinary tract symptom score. So that's why you use 5 on a daily basis, because of this particular paper. This is a study from Europe. It was essentially the registration trial for PDE5 inhibitors for lower urinary tract symptoms in Europe. They always have an active comparator, unlike the US who's placebo. And you can see the distribution in this study and symptom scores. Alpha blockers and 5-ARIs improve the symptom score. Can't discern difference. They work about the same. This is the BPH impact. I don't even talk about that. In this study alone, flow rate showed a change in this particular study, and most other PDE5 inhibitor studies. The medication does not improve flow rate. Doesn't change urodynamics. It changes symptoms, but not urodynamics. And there's a story behind that. This is a meta-analysis we published. I noticed when I looked at it this morning, it's mislabeled. This is PDE5 inhibitors on this side and placebo over here, so that's wrong. But essentially, looking at a bazillion studies, there's a distinct weighted advantage in terms of symptom improvement with PDE5 inhibitors. However, if you look at flow rate, no change. So this is kind of the consistent story. They improve the symptoms. They don't do much to urodynamics. One study looking at the combination of tadalafil and finasteride. It was a weird study, 26 weeks. What? But it was tadalafil and finasteride, that's the blue line, and then placebo and finasteride, that's the gray line. And essentially, that combination has some distinct advantages. Patients do have an improvement in their symptoms, as you would expect. They also have an improvement in their erection, which you would have expected. Because it was this kind of a one-off trial, it never really moved enough where we could, never really moved forward enough that we could use this effectively, let's say in terms of guidelines. But it's nice to have this in your pack. There's I think, a valid reason to consider these two medications concomitantly. Never took off the ground for a lot of patent reasons, that kind of stuff. But you can think about it. It's a short duration. 26 months is probably not enough for that. So summing up the PDE5 inhibitors, remember, they improve symptoms equivalent to alpha blockers. They don't change urodynamics. Why I keep saying that? I keep saying it because if a patient comes in urinary retention, even though we think they improve symptoms, the fact that you don't change the underlying urodynamics, both with residuals, etc., you probably don't want to use PDE5 inhibitors for that patient. That's where you want to use your alpha blockers, because that's a proven effect. It may work, it's never been really tested. And so for a trial without catheter success, depend on the alpha blocker. And so this is the AUA algorithm. It is going to change in the next calendar year or so. And I kind of put arrows in so you could see where I view PDE5 inhibitors coming in. And basically, wherever you use an alpha blocker, you could sub in a PDE5 inhibitor. It looks like it has the same impact, of course, with that one caveat about urinary retention. So you got a patient, he's got modest symptoms, his prostate's small, leave him alone. You got patients with moderate to severe symptoms, they bother him, he's got a small prostate, alpha blockers. He's got symptoms, a big prostate, think about combination. And this is this guy, big prostate, no symptoms. Is this a guy you ever want to meet in the OR? Think about that, because that might be the case where you could just do this, and because you're not really trying to impact symptoms. What about anticholinergics? This is just a classic one from Scott McDermott. Patients were given alpha blockers. They failed. They didn't have symptom improvement. They were brought back in, given alpha blocker plus placebo versus alpha blocker and an anticholinergic, in this case, oxybutynin XL. And what do you see? Well, you see some rescue, what we call add-on therapy. You can improve the symptoms adding on these two medications. And in these two classes of medications, and in the US, most patients would be treated with an add-on technique rather than a straight anticholinergic. Is there any risk with this? Well, look at changes in post-void volume, post-void residual volume. There is always a subtle, in these trials, there's always a subtle worsening of post-void residual. How much? It's under 20 cc's in most of those trials. So an insignificant but measurable difference. If you see down here, adverse events, defined as a post-void residual above 300, anticholinergics usually come in around 3% of men. Their post-void residual will rise above 300. Is there something dangerous about 300? We don't know that. We don't know if it's dangerous or not. We just know that when we do these trials, by protocol and FDA mandate, they get kicked out of the trial. So we really don't know what the implications are for having a post-void residual above 300. Some say 200, 250, 300. The trials vary in that regard. But what it has resulted in is that if you're going to use anticholinergics, you got to know the post-void residual. Otherwise, you're kind of hanging out there. When I was a resident, if I had a patient, he had urinary symptoms, and I said, well, let's give him an anticholinergic. They would get you out. Now, we realize that's completely inappropriate, that patients, we don't know what the impact of raising the post-void residual above 300 really is, but there isn't information to really guide us. And so we're kind of stuck to stick to those FDA mandates about patient safety. So I would just warn you, it's in the guidelines. It drives primary care guys crazy. If you're going to use an anticholinergic, know your post-void residual first, and you may want to check it on return visit. All right, Urologic Disease in America project is a project we've been doing around helping the guys at Hopkins, Brian Mataga, about this. I just wanted to introduce it. 10-year data following patients, Medicare patients and private insurance patients over a 10-year period of time. Why do I mention it? It gives us a snapshot of where we are today. Basically, medical management is increasing in our population. It increases by age, but also, like 80-year-olds more likely to get it than 40-year-olds, but also within each age group, we are increasing our medical management. So even though you think as surgeons, geez, we're still doing so much more surgery now than we did before, actually surgery rates are going down, medication rates continue to increase. So get used to it. Distribution of drug type, again, from the Urologic Disease in America project. Older Medicare patients have higher exposure to medications, private patients not. What's interesting is to look at the 60-year-olds, the men in their 60s, because they're transitioning from private into Medicare. You see a big change during that decade. And is that financial? Is that, Medicare is going to pay for it? So I'm going to go ahead and start the medications. It's not clear at this point. Anyway, you can look at the paper if you're at all interested. So one message we got from the Urologic Disease in America is patients, the frequency with which they come in, active surveillance for a number of years, then transition to medication for a number of years, then transition into surgery. You can see the percentage of no treatment decreasing by decade of life, medication penetration increasing by decade of life, and crossing over to surgery, increasing by decade of life. We can follow this very easily. And then men transitioning from medicine into surgery, you're looking at still single digits. So this medication exposure is still very high. What about botanicals? So this is a paper we published looking at dose titration, salt palmetto long-term study, published in JAMA 10 years ago or so. And long story short, no matter what you try to do, when patients are blinded and you have objective measures, salt palmetto at low, medium, and high doses, no impact on symptoms. There is no signal whatsoever. Despite 1,000 patients wearing Birkenstocks walking into the office saying that they had an impact when they took some kind of over-the-counter salt palmetto. You cannot measure an impact. And you can see we searched every measure I possibly could think of. We tried, and there is basically no signal that saw palmetto does anything. So when patients ask me, well, should I take it? One, it doesn't look like it does harm. I tell them, hey, the people that produce saw palmetto, they got to live, so you might as well buy it from them. No, I don't say that, but there's no measurable impact. Is it wrong to take it? No, because it's not killing them. But it's important that patients understand that it's more of a philosophy practice than it is a treatment. So that's not wrong or right, but they should be warned. I tell them, save your money. So I think that I am on time and on budget. I think this is an adequate summary of where LUTS BPH is. Been a lot of blinding streets on this field, and I think that urologists probably are represented very nicely by this blind guy right here with the white cane. So, Parth, happy to handle questions.
Yeah, it looks like there are a few. The first one is asking about your experience with insurance coverage for Cialis for LUTS, and whether patients are required to fail other medications for this issue.
Yeah, very common question. So I'll just say that we were the ones that, myself and a couple of colleagues were the ones that really first proposed PD-5 inhibitors as a treatment for LUTS. And I thought, God, it'll never catch on. No one will ever pay for it. But it turned out that was wrong. They do pay for it. There are some differences. So depending on whatever pharmacy plan they have, some more liberal, saying, yes, you can use it as a primary therapy. Most would say you need to demonstrate a non-response or an adverse event before that's going to be covered. That, I'd say, is the consensus of most. There are some pharmacy programs, and even within Medicare, there's a spectrum of pharmacy programs, coverage programs, and some will cover it, many won't under any circumstance. So it varies.
All right. The next question is about how you use anticholinergic therapy with the new research showing the risk for psychological side effects and neurological deterioration.
Good question about this issue of dementia, perhaps increasing risk of dementia. I would just say it's controversial, but it is a story that doesn't seem to be going away. So I have tried to move away from anticholinergics in my patients where I've decided they need something other than an alpha blocker. Tried to basically move them into beta-3 agonists, mostly because of that, but also discontinuation rates are more favorable with beta-3 agonists rather than anticholinergics. They don't have the dry mouth and this kind of thing. Coverage is an issue for sure. So if I get to choose, I will not use an anticholinergic. I'll use beta-3 agonist and try to steer away from it. In part because of that warning, but also there are other kind of nasty side effects of anticholinergics compliance, and greater than 50% will stop after a few weeks anyway. So because of those side effects, so I have moved away from it.
Thanks. Yeah, that actually covers another question about beta-3 agonists versus anticholinergics.
Yeah, so why beta-3 agonists in here? I'll tell you, because there's a very small number of papers which deal with beta-3 agonists as a treatment for LUTS. Most of those are add-on, failed alpha blocker, go on to beta-3 agonists. In the upcoming medical BPH guidelines coming out in 2021, we've addressed this, but I can't really spill the beans on that. So anyway, it's coming.
All right. There's another question about using alpha blocker or combination therapy in the acute setting. For example, the acutely urinary retained patient, or the post-op void trial failure patients, and whether there's any use with that.
So if you look at those timelines, the impact of 5 ARIs, they're not going to get you out of trouble. They're not going to. So really the focus should be on the alpha blocker. Is there any reason to use a 5 ARI then? Well, possibly. There is mixed evidence, but I believe it, that 5 ARIs impact hematuria. they impact vascular supply. You take a 5-ARI, within 2 weeks, there's a marked apoptosis of the endothelial cells within the prostate, so you can reduce bleeding. So if you have this patient, you think, well, he's a trial without catheter, but maybe we're going to make it or not. We might be taking them to OR. You might save yourself some hassle in terms of intraoperative bleeding. There's some evidence that shows you'll reduce that. Really not enough to change transfusion rates because they're so low. But so there is a potential role. But if you're not going to, there isn't evidence that you're going to impact a successful trial without catheter with a 5-ARI alone or in combination.
Okay. And staying on the topic of combination therapy, when, if ever, would you try to wean one of the medications?
We didn't show that slide, and I'll just speak to it. And there's anecdotal evidence. There were trials looking at dropping the alpha blocker arm. You start with combination therapy, go for a number of months or years, these trials, and then dropping the alpha blocker arm. Those trials were underpowered. They weren't really good trials. So it's really hard to say, well, the trials that tried to answer that question, can I do withdrawal therapy, dropping the alpha blocker arm, can't really answer the question. But if you look at the mTOPS curves, and I should have showed it before, I mentioned it. If you look at the symptom improvement scores and look to say where combination medication and monotherapy finasteride, where do they parallel? It's about 2.5 years. That's when they start to parallel. So the message, it's inferred from that. That wasn't the test at the time. It wasn't powered. We weren't asking that question. But the inference is that at 2.5 years of combination therapy, there doesn't look like there's a difference from 2.5 to 5 years between those two arms. So I think that means you could drop the alpha blocker after about 2 years or so. So that's, I think, the honest, most data-driven way to answer the question.
Thanks. Yeah, and so speaking of kind of long-term follow-up of these patients, can you speak a little bit to how you follow them, if you follow them for any kind of upper tract damage in the setting of long-term BPH LUTS treatment? And I will add a second component to that I was wondering. I know you touched on chronic urinary retention. How will you follow those patients who are not having symptoms or sequelae of chronic retention?
Okay, so I'll answer the first one first because it's easier, and then I'll handle yours, Parth. So how do I manage those guys? Well, if they have upper tract disease, upper tract hydronephrosis related to outlet obstruction, those are not medical managed patients. Those are patients that should be treated surgically. If you look at those trials, anyone with upper tract disease, they shunt out. So when I see, the idea is, if you've got renal compromise already, do you really want to take a chance with that patient's renal function by giving him a therapy that is going to be suboptimal? So if they have upper tract deterioration, medication's not, it's fine to temporize it, to get the catheter out while you plan for surgery. But in my view, that is a surgical indication. If you look at surgery, BPH guidelines, surgery, and I don't know who's doing the surgery component of this, urinary retention, upper tract disease, it's not medical treatment. That is a surgical patient. That's how I manage it. And that's what the guidelines say. Okay, chronic retention. So you have this guy, he comes in, you just met him, you got 500, let's say 500 cc's post-load residual. You did alpha blockers, he came back, it was 499. He's perfectly fine. He's got no upper tract deterioration. He's like, does he need an operation? Actually, I can't answer that because there isn't a magic point. But I have such patients who by mutual discussion between patient and myself, where we say, okay, we're not getting better. We can't guarantee you that surgery is going to be a help. And if you want to avoid it, avoid a surgical procedure, I'm happy to watch you. That's a guy I would keep on a short leash. I would recheck him. So how do you use it? I mean, the next question is, well, then how do you use impulsor residual? I mean, how many times I got to say it? We don't have good information on it. So when you don't have science, do art. And what is art? Art here is I do what I saw work when I was a resident. And that is patient comes in, his pulsar residual's 200. And he comes back 3 months later, 6 months later, now it's 300. And then the next time it's 400. So I'm looking at the trend line. I'm saying, well, sir, you know, I can't tell you what this means, but I'm concerned, you know, definitively, but I'm concerned that you're decompensating and that you're failing in medical management. And in this case, I think we should do a procedure, that we should do something to see if we can reverse that. And that's kind of old time urologic art. And I use that because I don't have anything else to weigh in on. And same issue is, well, what about urodynamics? If you did urodynamics and would that help you decide? No, because when you look at men who have marked hypotonia or atonia, catheter dependent, if you look at their, you know that, and you TERP those guys or do some intervention, TERP or Holman, because that's where the data is, that the chances that they're going to void catheter free eventually is 70%. So in a sense, the urodynamics doesn't tell you give it a shot or not. It helps you counsel the patient. Hey, there's a 30% chance I could do this for naught. Or look at it the bright side. There's a 70% chance if I do this, you're going to be catheter free eventually. Not you know, post-op day one, but measured in weeks and months.
All right, thank you. A couple more here. One, taking us back to the acute setting of urinary retention and talking about how long it would be appropriate to try an alpha blocker and let the patient fail void trials before considering urodynamics or surgery.
Well, let's just say considering surgery, because it's okay you could do urodynamics on day one, really. So let's separate that too also. Was it a provoked retention? Hey, he had a hernia repair when retention. Or was the guy just walking down the street and boom, I had a spontaneous retention? A guy who's provoked, he has a much higher probability, you know, he had hernia or anesthetic. He has obviously a much higher probability of becoming catheter free. So, you know, give him alpha blockers. I would give that guy multiple trials. I would say 2 trials is a minimum. That's my art. The guy who's, and I would try to be as encouraging as possible. Now, Bob Blackwell has a paper that showed when you look at those post-op retention patients, they are at higher risk of going into urinary retention downstream measured in years, going back into urinary retention. So you want to keep an eye on them. The guy had a spontaneous event. You cannot identify an inciting reason why his retention. The chances that he's going, even you give him alpha blockers and you get the catheter out, the chances that he's going to go back into urinary retention within 12 months is 68%. So on that guy, I give him we have a man-to-man talk, let's start thinking about an elective procedure for you because you want to be on an airplane when this happens next time. So I would manage those patients in that way. I give them that kind of counseling. So the easy answer is I would give them at least 2 for sure. And, teach them intermittent cath is actually the best because then they can self-regulate. And if you end up in the operating room, the men on intermittent catheterization, they always do better than men with chronic indwelling catheter. It's been shown multiple times. Intermittent catheterization, never wrong.
All right, and then the final question is about how you personally assess prostate volume and how you use it to guide decision-making. I think you addressed the decision-making part already. So
how do I do it? Well, I don't do a digital rectal examination for that reason. Most commonly it's ultrasound. If I'm trying to decide, hey, how big are you, and if I'm going to make a move, if I make a change, or make a decision, I'll cross over to surgery. I'm going to know his volume. There's a couple of ways to do that. One is, do one right there, or real time. The other is look in the guy's EMR and see, hey, did he ever end up in the emergency room? Did he ever end up someplace where he got a CT or an MR of the pelvis? And just take those images and have a smart resident come in if you want and remeasure his prostate volume. You'll get an idea of his volume. And the guidelines say, if it's been in the last, I think it was 18 months or 2 years, but that range, then that has got to be pretty accurate. So I'll always look for those. And if I can't find that, I'll do an ultrasound. And I make that, I look at volume drives surgical choice. So certain volume patients have all kinds of options in terms of what is the most appropriate surgery. As those volumes change or, vary, that limits when you can do when you should do one technique and not another. And the guidelines are pretty right on about that. So that's how I use it.
Okay, looks like we've tackled all the questions, and we just about run out of time. So thanks again, Dr. McVary, and we'll hand it back over to the UCSF folks.
Okay, wonderful. Parth, thanks a lot.